Welcome to High Impact Growth, a podcast from Dimagi for people committed to creating a world where everyone has access to the services they need to thrive. We bring you candid conversations with leaders across global health and development about raising the bar on what's possible with technology and human creativity. I'm Amie Vaccaro, VP of ComCare Growth and Strategy at Dimagi, and your co-host, along with Jonathan Jackson, Dimagi's CEO and co-founder. Today, we explore what it takes to get life-saving contraception into the hands of women in some of the hardest-to-reach communities. Our guest is Klau Pakos, CEO and co-founder of Lafiya, an organization tackling the family planning delivery gap by meeting women right where they are, through trusted local health workers they call Lafiya Sisters. In a single program area, Klau's team watched contraceptive use climb from 2% to over 70%. We get into how they built the evidence, why being a true partner to government, not a vendor with a fixed model, has been an unlock, and how they're thinking about going slow on technology, even when the shiny option is tempting. If you're working to scale anything alongside government, this one's for you. Enjoy. We are here today with Jonathan Jackson, my co-host and Dimagi's co-founder, as always. Hi, John. Nice to see you. Morning.
Hey, Amie. Great to see you as always.
Yeah. And today we're really honored to be joined by Klau Pakos. They are the CEO and co-founder of Lafiya. We are really excited to have you here today. So first of all, welcome.
Thank you so much. Yeah, it's great to be here.
Yeah. So for somebody hearing about Lafiya for the first time, what do you do and who is it for?
So Lafiya solves the family planning data and delivery gap, currently focused on Nigeria, but we're looking at the universal access to family planning as our big vision. And at its core, that there's highly effective and affordable contraceptives out there, but the health systems struggle to consistently deliver the services at the last mile. So Lafiya solves this by meeting women where they are with trusted Lafiya Sisters, high quality family planning counseling, and available stock.
That's awesome. What was it about the women that you met in northern Nigeria that made this the problem that you decided to build your entire life around solving?
I started working in Nigeria almost a decade ago on a different project. I was a consultant for the Ministry of Energy, designing a training curriculum for female entrepreneurs, from cleaner cooks so they could get some money from the usage, and from that start their own micro businesses, such as selling peppers from the field on the market. But the requirement was undergo a few weeks of a micro enterprise course at a local university or a local school to cover things like taxes, loans, accounting, basic but very important things for sustainability. So we essentially worked with women living in extreme poverty and being given free money and a chance to get themselves and the family out of poverty. And they couldn't join because they're mentioning how difficult for them it is to actually commit themselves to a course like this, because they have no decision making over when the next time they're going to be pregnant. And they had the need and they didn't have the products, and the health workers could be able to provide them with information. So that experience was really eye-opening for me, because I realized that there's so many exciting and fantastic global health and development projects out there, but there's just this fundamental level that if it's not fulfilled, it will become a barrier for all the other programs undertaken and to be scaled.
Yeah, that's really well put. That sort of control and autonomy is like the starting point for anything else that comes after. I'd love to hear if you're willing to share about a client that you'll never forget, and maybe as you share that story, like a little bit more about like the model and how it works in practice.
Yeah, there's so many different clients, but there's one that I keep on thinking about often. I was last year at the community visit in Kebbi, one of the states we operate in. And it was a very long day. We talked to so many different health providers and so many different clients to better understand how we can adjust, adapt, and change our program for their needs. So we were almost closing. There was a woman coming over saying, no, please, like, I really need to share my story with you. So she was explaining how she was pregnant. That was probably like 2 years before that, and had a really difficult labor and was recovering. And then she realized that she's pregnant again. It has only been a few months since her last labor, and it was her fourth child would be. So she went to a local clinic to get a scan with her neighbor who was a doctor. He saw something on the screen, got really pale, got really scared, and said, like, I cannot tell you what's going on, but it's really scary. And then the same thing happened with another friend of hers. And then at the end, she went by herself. She's like, I don't know what's going on. Everyone is really scared. I am feeling very anxious and I'm pregnant and I am still recovering. It turns out that she had twins and one of the twins was dying in the womb. So she had to have an emergency C-section 6 months into her next pregnancy. She almost didn't survive this. Like she almost could not go through this experience. She survived, her other baby survived, and she is now at a very high risk of mortality if she gets pregnant again before she has time to properly recover. And she actually came with her husband. Her husband was saying that he was grateful for availability of services like this because that saves his wife, the woman that he really loves, and the mother of his children. And then she can provide the care for her 5 children. But I mean, the story itself just felt so visceral. I think the fact that she got there, it was very hot. It was maybe like 6 p.m. after a very long day. She's like, I really want you to hear my story. And I'm really grateful for this. I really don't want this program to go away. So when you're making decisions about where you're going to be expanding, where you're going to be working, please don't leave this. Yeah, I think that story just stayed with me for a very long time.
Amazing. And, we hear just so many of these challenges where such obvious life-saving technologies and interventions would do so much good in the areas that are hard to reach. And I know one of the things you solve for with the Lafiya Sisters and the regions you work in is you're working in some extremely difficult regions to serve any interventions, much less family planning. And so I'd love to hear, what do the Lafiya Sisters do? How did you land on that model? And what are some of the challenges? Because I work at Demagi, your work, everybody knows that the whole root programs are these amazing community-based workers, but it's just really challenging to run effective programming, and you've cracked it. So I'd love to hear, a little bit more about the model in general, but also just how did you evolve over the last 5 years to get to the model you currently have?
Yeah, so the lifestyle model came from a very simple thought that you trust your system more than you trust a stranger, especially with something so sensitive like family planning, because you decide about your body, about your family, about your future. And it's hard to rely on external information, would be, again, from a doctor or online or from a radio. You need someone who understands you, who you can trust. So that's exactly kind of what the Lafiya model comes from. So we first identify left behind communities with high unmet need for family planning, often don't have any access to health services, don't have access to family planning products, to the information. And we work really closely with the government to, first of all, identify which regions in the country are underserved communities, which are not underserved, has the highest need for family planning. And afterwards, we go a lot more granular to local government area level, to LGA, and afterwards even further to communities. From then, we recruit and we train existing female health workers who already work in health facilities with additional family planning training so that they can become persons sharing the information rather than bringing them from the outside. We find people inside who already work as a nexus between the health services and the communities. And then they're called Lafiya Sisters. So they deliver proactive, app-enabled family planning counseling and services, and they meet women where they are, at home, communities, local weddings, and local celebrations, markets. That's where the women are, and that's where the communication is the easiest, and the trust is the easiest to build. And Lafiya Sisters counsel on all methods of family planning, making sure the woman can make a decision that works best for her. They also leverage the existing stock in health facilities for community-based products. So things like pills, like condoms, like the different types of injectables, all of it, if it's available, they are able to provide and bring into the communities to meet whomever they are. But the issue that we are seeing is that there is just very big stockouts. So often women are being sent home empty-handed. And I think this is just so heartbreaking. Imagine finding something that works, being told about this benefits of this incredible kind of new solution, and then saying, I'm sorry, we don't really have anything for you. Maybe come back a few months later when they've been a long time for them to travel to get there. So we made a decision to also ensure there's at least one product always available. So there's no one being sent home empty-handed. And the product that was the most popular among our communities is the MPAC, also known as Cyanopress under the marketing name. So it's this really interesting contraceptive that can be self-injected. So it doesn't require a health worker to mix the solution. It's just as long as you know how, you've been trained how to do it once, you can do it at home. It kind of looks like an insulin shot. It lasts for 3 months. It costs 90 cents and it doesn't require cold chain. it also has fewer side effects than a lot of other types of contraceptives out there. Now that it lasts for 3 months, it's enough time to not require everyday visits or every week visits, but also is perfectly suited for the main need that our communities have, which is not necessarily to stop having children whatsoever. It's just to have a break between pregnancies, between labor, and to have enough time to rest. So they're usually looking for a year, 2 years, maybe 3 years of a break between children. And Lafiya Sisters can teach a woman who's interested in self-injection and leave her with 3 additional doses home. So for the next year, she's protected. And that reduces the number of visits, that reduces the transport. It's also very discreet. Again, I said it's like an insulin shot. So in conservative environments, it's up to their decision whether they want to share it with their community or not, because that's become their personal fertility decision, as opposed to, for example, implants that can be made more visible, or pills or condoms that obviously are easier to spot someone using this. And that was the heart of the model originally, was doing this well and getting to the woman. Our pilots took place 5 years ago. It cost us $6,000 because we had a very small budget to start with. So we had to be very cost effective because we didn't have money to spare to not be cost effective on that. And we originally thought that there's going to be low demand, that women are going to find it, they're going to have some level of skepticism, of misunderstandings, of misconceptions. But no, we went through the stock that we bought very fast within 2 months. And then we had to buy more stock because the women are coming back, knocking the doors of our Lafiya Sisters and asking, hey, I heard it from my friend. I heard it from my sister. I also would like to use this product. I also want to use family planning. So the demand was a lot higher than we anticipated, than the research has shown. I think that's partly because there's been a lot of programs done to increase the level of understanding, generate this demand via radio, TV shows, in-person outreaches. The gap was a woman has heard about family planning and its benefits, but is struggling to figure out which option is available and perfect for her at that point, given side effects, given eligibility, given her fertility plans, and then actually connect her with the product itself. So making it convenient at their own doorstep by someone who they can trust because they've grown up next to them in the same community, makes it just such a easy way in. And that's why over half of our users are first-time users. So women before never used contraception, but this was just a good start for them to overcome their initial skepticism. So that was the starting point. You asked me, John, how we've evolved. Nigeria is a very big country, and Sub-Saharan Africa is even bigger. The demand for family planning is really high. We're talking about 1 in 4 women in Sub-Saharan Africa who lack contraception and doesn't have access to it. That's 70 million women. And Lafiya is doing well and is growing fast, but that's a lot of people to reach at the same time. So realistically, the main actor that can lead to scale is the government. And that's what's been redesigning for governmental implementations from the very beginning. Like our training is provided by the family planning state coordinator, the health workers, the Lafiya Sisters are already on the governmental payroll. We pay them additional stipend because they're working additionally with us in communities, but they're already governmental health workers. And a big gap that there is properly and accurately forecasting the demand. And if you've been working under the assumption that maybe this health facility requires 200 injections over a quarter, but you don't see those 2,000 women that came over for a visit and went back home empty-handed. You don't hear about the women in communities who don't even bother to make a trip. There's constantly underestimating that it compounds over the years, and that creates a very big gap in understanding what is realistically needed by the Federal Ministry of Health to procure to really fulfill the needs of women in their communities in the country. So our work continues doing a lot of work in the communities, but working really closely with the government to solve for its issues, solve for its gaps, to improve demand visibility, forecasting, and supply planning.
That's great. And such a cool journey. You mentioned trying to get this going with $6,000, which is not a lot of money. Remind me, did you come through a kind of incubator, like peer startup community for impact-focused people?
We got our first grant from D-Prize, from Distribution Prize. So that was our first grant, was $15,000. And again, 13 health workers and a lot of can-do attitude. So that was the starting point. Approximately a year and a half in, we've also taken part in the charity entrepreneurship incubator that helped us going, I guess, from the pilots to an actual project and afterwards to an organization. Charity entrepreneurship usually identifies high cost-effective opportunities for charities to be started by entrepreneurs and be able to achieve this impact. Latvia has gone through a different path than most of them because we came with already existing model and program. And our results from the pilot were cost-effective enough to be able to compete with some of the top charity leaders that they had. That's why we worked with it into the incubator and went through this as well. That was very helpful for our journey.
That's great. And we have the pleasure of talking to a lot of the amazing founders that have gone through that program, and it's just phenomenal. The innovation and the cost effectiveness of a lot of the charities that have come out of that program. On the cost effectiveness side, you mentioned, you're leveraging government workers, you're topping up their salary, but you're delivering something that costs 90 cents per dose to hard to reach communities. So I imagine the cost effectiveness of your program is pretty amazing.
Yeah, yes, we were trying to leverage an existing investment. So on top of the leveraging on existing governmental staff salaries, the product itself, Synappress, it costs 90 cents because it's also subsidized already by some public partner like the Gates Foundation and Children Investment Fund Foundation. So we're able to bring the existing already investment further. And I think that really helps us bring the cost low. Similarly, we also, again, as I mentioned, we work with women in the communities already. Like we're very decentralized, and that helps us closely connect and decrease our logistics and supply chain and all the different kind of things cost significantly. In terms of the cost effectiveness, we've had the pleasure of working with Think Priorities a year ago on our modeling. It cost us to avert one maternal daily and $2,451 to save a maternal life. So that's a number we're proposing in terms of the cost effectiveness. In terms of providing one woman with contraceptive coverage for a year, it's $5.60. So for $5.60, we're able to cover the cost of the health workers that we are covering additionally, monitoring and evaluation systems, the cost of the commodity itself, which is the vast majority, if you count it like 90 cents times 4, additional logistics costs as well, the supervision of the health workers, the transportation, communication allowances, all of it is combined in that number. This would be realistically what would the government be paying if overtaking the model as it is right now to cover one woman with protection from unwanted pregnancy for a year.
That's amazing. Like the cost effectiveness that is, I've seen some of the models in there that it's extremely high. As you think about, both government adoption and country expansion that Latvia is now growing to, I'm curious how you think about that, because one of the challenges we see a lot of really effective enterprises have as they get to the phase you're at, we've talked about this, how do you scale? You've obviously put a ton of your own personal time in, your team's amazing. That's not necessarily replicable, in the next country you go to or with the government. So you can deliver it at 560. But how do you think about, whether the government can achieve that, whether the next country can achieve that? And what are some of the concerns your team is talking about as you choose the next country to scale to and as you expand within Nigeria as well? I'd just love to hear how you're thinking about that. And obviously, you should just be using Connect while you do it.
Yes, thank you. Thank you for this plug as well. The good thing about Nigeria is that it's decentralized countries. It's a federal country. So we have an opportunity to see how our model works. At every state, it's something else. And we're currently in 4 states operationally, and we just got expanded into a 5th state. We had our reception meeting yesterday, so actually in Bauchi, which is very exciting. Thank you so much. Yeah. And we're going to be expanding to 1 more state over the next few months in Nigeria. With that experience gives us a lot of insight into understanding what needs to change and what stays the same. So what is the Lafiya Sisters core model pieces, and what are the things that needs to be adjusted? And I really like about these adjustments because for family planning program to be effective, I think something that's probably already well known in this community, it needs to be hyper localized to the community needs, because such a sensitive conversation to have that even if you use the wording, like the message will not land. If the message will not land, you're not being able to have honest and informed conversation. For example, when we operate in the northern Nigeria, we use the phrasing of child spacing rather than talking about family planning. I think it's an illustrative example to show the hyperlocalization that we're doing from state to state. So with the scaling, trying to understand what are the key elements, the ensuring that there is stock, ensuring that the Lafiya Sisters are from the communities, that we are working when no one else is working. Like we're going to the contraceptive deserts, the poorest of the poor who have no other points of connection with healthcare systems. That's, I think, what's going to stay, because that helps us achieve the mission of universal access to family planning. We want to be part of a bigger puzzle to ensure that kind of we can cover where private sector or public sector or other NGOs may not go. And another part that, as it's very crucial to this, is sustainability. So even though Latvia has a very cost-effective model, we're also planning for the government to not only undertake the implementation further and further, like they've already taken a big chunk of it through the recruitment, training, and supervision, but also cost. So with 2 out of the 4 states we currently are working, we've got commitments from them to increase spending on family planning. And the way we think about it is a kind of a one-on-one matching solution. So to start with, and afterwards in increased provision from the governments. So states in Nigeria right now can use their own domestic budget to buy more contraception and cover exactly the same gaps that I was talking about at the beginning about the stock-up gaps. And Latvia can incentivize it further by saying, we're able to provide, for example, $100,000 worth of press of the MPAC, if you're also going to be spending $100,000 on family planning commodities. We don't specifically say which ones, because they have the data to figure out which one are the options needed by the users in the region, and want to ensure there is an expanded method mix, so women can choose whatever method she wants to use, rather than kind of promote one specific product. And that's going to be also part of the scaling from the very beginning. So now with any state that we are expanding to, that's part of the conversation, rather than kind of starting working there and kind of, I guess, proving the value and showing the evidence of the impact on the contraceptive uptake and other health benefits. Now that's a starting point of the conversation. So in terms of country expansion, it's very exciting. It's still in making. We have a shorter list now, but one key thing that we're going to be changing in between our new country model and this model is that we would like to disaggregate our impact of 2 different things we're solving for right now, because we're providing stock. So that's one part of it, is solving for stock outs. The other one is getting the stock to the hard-to-reach communities through the Lafiya Sisters model. We've had a study done a few months ago that showed that in our treatment area, uptake increased from 2% at baseline to 56% at midline in 8 months to 72% at endline. So after 18 months, from almost no one using contraception in that area to 3/4 of women using contraception in that area. So that's a 39 percentage point increase over the counterfactual as well. Not only seeing this huge uptake in the treatment area, but also seeing the counterfactual uptake as well. But this number is really big. I mean, it's not bigger than we're even hoping for. And I do think that is because we're solving for those 2 issues at the same time. With the expansion of the country, we want to leverage an existing stock in the health system already and see, just with Lafiya Sisters model, using whatever is available in her facility, if it's provided in a more convenient way at home, in the communities directly with the women from the same villages, from the same regions, what is going to be the impact that we're going to be seeing. So that's the main change of the model that we are doing. Yeah, fingers crossed. Currently trying to figure out exactly the data on stock, how to figure out exactly how much stock there is in the system and how much it's needed is honestly a pretty challenging task. So yeah, we're currently hiring a few more staff members to be able to help us with this transition and scale process.
That's amazing. You mentioned 2 things, these amazing results on increasing coverage in the counterfactual, and the idea that you're getting governments to buy in now on communities you've already been in and states you've already been in Nigeria, but also as you go into new regions. I think that's the goal of many social enterprise models, is how do you get government adoption? So I'm very curious, was the challenge that you faced in getting governments to contribute funding a evidence problem that you've now solved because of this 18-month study? Was it a advocacy challenge? Just can you talk us through how you successfully engaged the government in those discussions? Because I think so many of our listeners, that's their goal, and it's really hard to actually get the government to write the check, right, and to contribute to it. And what do you think unlocked that? Was it evidence? Was it something else?
It's a great question, because it's also a similar question that I've been having with a lot of different Nigerian practitioners and implementers and trying to learn from their experience. The Nigerian government has been dedicated to family planning for years. It's been the Family Planning 2030 contributor for 10, 15 years or so. It's really dedicated towards this. So there's no issue regarding prioritization of it. I think the main challenge has been, and still is to some extent, capacity there's just a number of competing priorities that are all important. It's very hard to have a conversation saying, let's deprioritize conversation about malaria because we need to talk about family planning, or, let's talk about having births in health facilities because, we're discussing contraception. I think, honestly, that's the biggest challenge, especially for a country as big as Nigeria. It's 220 million people. It's growing very fast. It's over 4 children per woman right now in terms of populational growth. The challenges and the burden on the healthcare system is just really big. And the implementation falls upon states. And again, that's also harder. So something that I think has been working well for us is to truly live what we're saying, which is we want to be a partner to the government, understand where are the gaps that they identify and help them solve for them. Because if they need capacity, if they need an NGO to do some field work, to get some data, to do some analysis, we are the partner to do this. That's exactly what we want to fulfill. And we truly want to be a co-creator, like a co-partner, rather than setting up an existing model saying, this is it, please take it up. So trying to solve the capacity issues for the government and understanding this. We have a really good programs and advocacy team who's been working alongside our governmental partners for years, for 15, 20 years in both national and state level relationships, which I think really helps because it creates this personal trust as a part of the conversation. And evidence has been also helpful. I remember particularly working with one of the state governments who have already committed their resources, Sokoto government, with also very high maternal mortality rate and infant mortality rates, sharing the results of the study that actually took place in Sokoto itself. And just like, this is great. We want it. Like, if this works and I can show it, absolutely, we would like to be a part of it, how we can best work together. How you can, for example, and they say quite specifically, like, there are issues, for example, data accuracy, there's issue with stockouts. What can you do to support it? So rather than trying to push a model forwards, being a listening partner and a co-creative partner is just so important. Something that's been an unexpected development is that actually the Federal Ministry of Health has asked us a few months ago to lead the development of an electronic family planning tool, counseling tool for the entire country. We do have a very rigorous monitoring and evaluation. Every single point of counseling, a Lafiya Sister fulfills, and as I mentioned, like basically in her app, a short survey that also has guided prompts that help increase the quality of counseling and keep better information about the users so that we can improve our services and then we can target the truly under-resourced communities the best. But after sharing this with the Federal Ministry of Health last year, they came back saying, this is great. This works really well for us. It's available offline. It's really low touch. And we've been thinking about digitalizing our health records for such a long time. Can you work with other partners? That's what they're doing, work together and run a pilot so we can see whether it could work across our own system as well. So this is still early days. It's been only a couple of months working on this. And between aligning all the tools and piloting them and getting the sign off and implementing, it's a long journey ahead that I am aware of. But I think that's, again, a good illustration of if there is a specific gap, that we are very happy to work to fulfill it.
That's awesome. As I'm listening to you, like, there's so many beautiful kind of best practices coming out from what you're sharing around, like, it would be so much easier for you to just be like, look, this is our model. Like, we're going to implement it here. But actually, instead, you're saying, like, let me come alongside you as a government and understand what are your gaps, what are your pain points, how can we help solve them? And also, I have this incredible model. And you're seeing the rewards from that in terms of governments wanting to partner more deeply with you and even scaling some of the tools that you've developed. That's really cool to see.
That's why it's harder to discuss exactly how scaling can look like. It's challenging to sometimes set up a very clear 5 strategic plan of what we're going to be doing exactly when, because we don't really know what our communities need, what's going to change in the landscape, what's going to happen with other partners, what's going to happen in our landscape. It's very hard for us to be able to anticipate this. We obviously have some part where we might get and in what pace, but realistically, we need to stay agile and be able to adjust to we can provide the most long-lasting support.
I'm curious, like, with this government, with the idea of sort of transitioning a lot of this to the government, like, what does wild success look like for Lafiya in like 5 years? Like, what would you want the government to be running? What do you imagine like that handoff to look like once kind of the government takes over more?
The gradual transition of the Lafiya model, both the implementation and the financing part, would be the wild dream, and be able to do it in multiple states. So afterwards, we can have a lot of lessons from that and we can be able to scale even further, right? Even faster, we can be able to share the best practices for other organizations. The way that we prioritize it comes from what's the biggest cost item that we currently have is paying for. And right now it's commodities. So the focus is let's increase the amount of commodities in the system. Let's cover for this. And that's our primary focus in conversations regarding the cost sharing. Additional cost items like the additional stipend for Lafiya Sisters. Actually, one of the state governments has expressed that they're really interested to cover this. They came out of that, which is very cool. So we'll see how this conversation is gonna go. The additional monitoring evaluation cost, which to some extent the vast majority of it is already existing spot check that the government is doing, or this digital family planning tool that I mentioned. So if the national government can use, that's once again another item of our list. I think those are the four main things. The fifth one is the supervision, which is already again ingrained in the health system because the health workers working obviously already have supervisors. So we're trying to see whether we can increase the amount of commodities in the system. It's also like a self-fulfilling prophecy, right? If we're able to increase dramatically the number of commodities in the system, we're able to better understand what is the true demand. And by solving that, again, the government can continue improving its demand forecasting. It's just about the first initial push of products into the system to see whether there are enough recipients, whether there's still a gap. Lafiya also captures information not only about how many clients we are seeing in terms of counseling, on how many people have been provided with different products, but also what was the first method that they chose and was it available there or not. So if a client comes and she asks for an IUD, but an IUD is not available in a facility, we do keep information about that. We can continue sharing. So that's already an important piece of information to also have in terms of future demand forecasting. So in 5 years, having more product in the system, fewer stockouts, better data accuracy, and figuring out how to bridge the gap, last mile, the beyond the health facilities, the middle of nowhere, really remote rural communities that are just really difficult to reach. So that would be the wild dream in Nigeria itself, and be able to see its also used and be able to see also tested in other countries as well.
I'm curious, do you feel a tension as you've been growing and getting this traction? So you mentioned how it has to be like hyper local. And then the government's like, oh, great, you solved it, create a national system. And you're like, well, that by definition doesn't work. You didn't hear what I just said. It's got to be hyper local. And then you have that problem also of like, you're doing this amazing job on family planning, but the Lafiya Sisters do other work, the clinic does other work. How does this all get integrated together? So one of the things that we've really seen our customers and partners struggle with is like when they control everything, it's amazing. They can be extremely cost effective, they can innovate, they can be responsive, they can hyper localize it. And then as you think about how a government could own this, exactly as you said, because there's limited capacity, they can't be hyper tuning the system, all the time. They can't be thinking about this all the time. How do you view that? Is that a tension you're feeling right now, or does it feel pretty aligned in terms of the innovation, localization that Lafiya is capable of doing versus what a government might be capable of doing as they take it over and scale it?
I think you're anticipating some of the tensions we're going to be feeling soon. I think currently the biggest one that we're seeing is it's been really difficult for us to get to. They're not very receptive towards vaccines. They're not receptive in facility births. They're not very receptive to health systems in general. Can you do more? Can you provide more fix? Can you do more services? And the further integration is obviously something on our minds, especially if we can find a cost-effective way that really responds to the community needs. Very careful about this. We're very slow to commit to anything because building expertise takes time. And we want to make sure that we can do at least one thing very well before we start committing ourselves to doing 3 or 4 or 5 things and instead working on partnerships. The localization question is a very good question. I think that's why we're currently scaling also in the South in a different cultural, religious, and language region than our previous expertise, because we do want to bring those practices and those learnings already on board. So to give you an example, this chronic time planning tool, you can switch language, and we really want to make sure that the language that is being there is not English as a national language in the country, but it is the local language that people will feel more comfortable using. And if people don't speak English in rural Jigawa, why would counseling tool be in English and then the health worker has to translate it? Let's make it in Hausa. But let's, in the South, let's make it in Yoruba, let's make this the exact language that conversation is going to be taking place. And so there's already some lessons there, but I think it's going to come down to implementation. To some extent, we are both supporting federal government, but our primary key partners in the conversation is the state government because they're tasked with the implementation of the guidelines, policies, and laws. That's also what we do. It's the implementation. So we work with them hand in hand, and we try to bring practices more on board.
I'm so curious, Klau, you've mentioned in a number of your responses, you've mentioned an app, you've mentioned a digital family planning tool. You sound like you're very like tech forward. And I'm just curious to hear a bit more on like what's been your journey with technology as you've founded this organization and how is it helping? What are the stumbling blocks? Like, how are you approaching it now?
Yeah, the main thing I think that I learned is not to get excited about tech too early and too much, because there is a really cool solutions. And I like a lot. I think it's a great way to automate processes, to be more effective, to solve issues that normally before we really struggle to solve. But really understanding what's needed and what's shiny. So our communities often have very bad network connectivity. There's almost no network. So a lot of really cool AI tools that I would love for us to be able to using, realistically, will make it too difficult, too heavy, and only available online. And that would take away a lot of functionality away. We also, for example, have voice reminders and text reminders for women who've been using contraception to ensure they remember when is the next time they should inject themselves. Again, we do have this functionality, and around 15% of our users really like it and really appreciate it, and they don't want to go anywhere else. But only 15% of our users can do it because they have access to the phone, the sole owner, that there's not, for example, a family phone. For them, it's a useful feature. So we're trying to understand what solves an issue and what creates more issues. Technological changes were very slow and steady. Something that we've been thinking about, actually, which is a work in progress, is better identification of our users so we can track their continuation journeys better. Our communities don't really have health records often. They're not really signed in any kind of health system. So being able to track the same person over multiple years of engagement with the same health worker becomes an issue because you don't have an ID document that can help track them. So we're thinking of using some more developed solution or like face scanning or fingerprint scanning or something else that can really bridge the gap. But before we go anywhere there, we really have to first understand, will our users be okay with this? Will they be willing to be part of it? How would it look like? What is the training that is needed for the health providers to be able to do this well? How do we explain all the guidelines, ethics, and consent considerations before introducing something like that? It's a long process. Like, even though we've been talking about this for a few months already internally, it will probably be a long process before, if it is even something that our users would like to become operationalized. So trying to be really considerate and really, really slow about those changes.
I really appreciate that like slow approach. I think that's super smart. So thank you. Thank you so much for sharing that. Klau, what's something about this work that the data will never quite capture?
Great question. I feel like the data captures the health benefits, that some also the income benefits. I mentioned maternal deaths averted, DALIs, and we really care about those considerations because they really help us understand whether we are right on track, whether they're using the resources well, whether we are highly cost effective or not. But I personally care about family planning because it's so much more than that as well. As we mentioned, it brings the foundation for everything else. It creates ripple down effects on families and generations. One of the best ways for, to ensure that an under 5 infant is going to survive is if the mother survives. Able to provide safe space for families, safe for children, communities when there is more gender parity, that women can start their own businesses, can continue education. All things that are not captured as easily. There are obviously some great models that are trying to connect on this level of autonomy and agency that family planning, that contraception brings with itself. It is just so hard to capture with data. And I wish we could. I wish we could be a bit more about it, but on our side, we always try to be very conservative with our numbers, not to overpromise, not to overestimate anything. So some of those benefits are just kind of lost in translations when we talk about the effects of the program.
Yeah, that's so well put. And I can feel like all those intangible and hard to measure, but like super important things that are also coming out of this program. Awesome, Klau. Well, this has been a really wonderful conversation. I feel like I can ask you many more questions. I'm sure John could as well, but I will be mindful of your time and close us here. Thank you so much for joining us today, and really excited to share this conversation with our audience. And there's so many great nuggets of wisdom that you've learned along the way that I know will be immensely valuable to our listeners. So thank you so much.
Thanks a lot. This is great.
Thank you so much for for great questions, and also for putting together the podcast and creating this conversation, the space for reflection for the entire sector. I really appreciate it as well.
Awesome. Looking forward to connecting. Thanks.
Our pleasure. What a rich conversation. Huge thank you to Klau Pakos for sharing not just the results, but the hard-won thinking behind them. And thank you, dear listener, as always, for being here. A few things I'm taking away from this one. First, the family planning gap Lafiya identified wasn't awareness, it was the last mile. By the time Lafiya arrived, years of radio and outreach had already done their job. Women knew about family planning and wanted it. What was missing was the final stretch, help figuring out which method was right for them and a product actually in stock when they asked. Too often, a woman would travel hours to a clinic only to be sent home empty-handed. Lafiya closes that gap with Lafiya Sisters, trusted health workers from the same communities who bring counseling and supply right to where women already are. Second, an incredibly useful insight for anyone working on government buy-in. The barrier often isn't evidence, it's capacity. Government had prioritized family planning for years. What unlocked the partnership was Lafiya offering to absorb the work. Third, know what's actually driving your impact. Lafiya solves stockouts and last-mile delivery at once, and they're now pulling those apart to see which really moves the needle. And finally, a through line in everything Klau shared: go slow and stay local. Lafiya found that child spacing as a message works where family planning doesn't in certain parts of Nigeria, for example. And be honest about what technology solves versus what just looks shiny. That's our show. Please like, rate, review, subscribe, and share this episode if you found it useful. It really helps us grow our impact. And write to us at podcast@demagi.com with any ideas, comments, or feedback. This show is executive produced by myself. Prathana Balachandar and Michelle Abulencia are our editors. Natalia Glowacki is our producer, and cover art is by Sudhanshu Kant. A final note in the spirit of transparency: we use AI to assist with guest research, copywriting, and post-production, so a small team can produce a high-quality show. All AI-assisted content is reviewed and edited by humans, and we retain full responsibility for what you hear.